Namaste and greetings. I, Samprikta Banerjee, a researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evam Niti Anusandhan Sansthan, Nayi Delhi, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today marks the third day of Healthcare and Gender Equity, Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges, an online international monsoon school program, a 4-day immersive online certificate training course. This program is organized by the IMPRI Gender Impact Studies Center, GISC. This program has an excellent panel of experts who will be sharing their expertise for the duration of this program. The distinguished expert panel includes Professor Vibhuti Patel ji, Professor Linda Lane ji, Ms. Jaya Velankar ji, Dr. Padma Bhate Deosthali ji, Professor Brunel D'Souza ji, Dr. Amar Jisani ji, Dr. Aqsa Shaikh ji, Dr. Veena Vaswani ji, and Dr. Anant Bhan ji. The conveners for the program from IMPRI are Mr. Farhad Yenepoya ji, Professor Vibhuti Patel ji, Dr. Veena Vaswani ji, Dr. Manorama Bakshi ji, Dr. Swati Santosh Rane ji, Dr. Simi Mehta ji, and Dr. Arjun Kumar ji. Proceeding further, I heartily welcome you all to this course, Healthcare and Gender Equity, Cohort 3.0. The transformative power of gender equality reverberates across health outcomes, fostering benefits for the individuals and communities alike. Hence, this upcoming cohort of healthcare and gender equity unfolds as a crucial space for collective exploration, promising deep insights and contribution to the discourse on transformative inclusive healthcare systems. We hope that you take back a plethora of knowledge and valuable information from this course, which will effectively aid you in your respective fields, along with causing a notable improvement in your skill set. We have also shared the course outline and reading resources via email for your kind reference and perusal. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the question to save time. Without further ado, let us begin with the program. I'm delighted to invite Professor Vibhuti Patel ji, visiting distinguished Professor IMPRI, for her opening remarks of the day. Over to you, ma'am.
Yeah. Thank you, Samprikta Banerjee, for introducing the course. Today we are on the third day. We had a very lively session previous 2 days, and I welcome Dr. Padma Deosthali, Dr. Aqsa Shaikh, and Dr. Swati Rane, today's expert, and also express my heartfelt thanks to co-organizers, IMPRI team, led by Dr. Arjun Kumar and Professor Veena Vaswani. A brief recap of what transpired so far. The day one, we had a very important paper presentations providing perspective. Jaya Velankar, a veteran feminist, she provided the whole understanding on gender and health, and also gave so many examples of her organization Jagori, and in the women's movement, what all have been taken up in terms of health rights. And she also said that Jagori was the first organization that had contested the mental health approach of the state and contributed a lot in terms of women's reproductive right and overall health. Dr. Amar Jesani brought in the ethical dimension in the gender and health discourses, and he also gave a history of nearly 200 years of history of modern medicine, and how the witches, women, the traditional healers were treated as witches, and how the modern medicine, medical science, and the healthcare services are resting on the ashes of 1 million witches which were killed between 13th and 18th century. And he also talked about the patriarchal model of health delivery system that treats doctors as a father figure, nurse as a mother figure, and patients as children, and they infantilize. And the conflict which is recently we have found is mainly because of this kind of a patriarchal bias, which is based on control and the whole mystification of experts who control the discourse, and the nursing, the healing that is always given a subordinate role within the medical hierarchy, while the diagnosis is considered to be the supreme. And he says that we need to change and we need to do rethinking about this kind of hierarchical organization of the medical services. Yesterday, Dr. Linda Lane, she started with a question of accountability in the maternal health care, and she also promoted provided rationale for intersectionality approach. And she said the accountability in healthcare services in terms of financial accountability, performance accountability, political and democratic accountability, and social accountability. And she also gave example of Serena Williams, who had such a difficult who got the best medical services, but when she developed postpartum complications, doctors were in denial mode. She suffered a lot, and finally, they agreed, and they did the re-examination, and there were blood clots were found in her lungs as well as in the area of C-section. So she said that your wealth may not save you. So it is very important that the patient care and patients' voices are heard. And they said if it could happen to a person like Serena Williams, you can imagine what would be happening to women who are from the marginalized sections. She also gave example of her studies in India, where she saw that so many women from the ethnic minority, tribal women, they never had a privacy when they delivered babies, and they were delivered in the PHC when everyone was seeing. So they said the privacy of those women were not respected. And then she also demanded the decent working hours for nurses and the healthcare workers who are overworked. And she also said that we should the healthcare services should stop criminalization of LGBTQIA plus community. And there were ample examples were also with her. And finally, after that, even Dr. Professor Veena Vaswani's very, very passionate presentation on health, gender, and climate change. But she began first with her personal testimony of the difficulty she had faced when she delivered her first child. And though being she and her husband both being a doctor, the insensitivity with which the hospitals there treated her. And she says it is so important in this field that if you know someone, then you get good care. So when you are unknown, even if you are qualified, you know everything, you don't get the services. And this thing should be changed by the certain standard operating procedures that we need to have. While talking about climate change, she mentioned intragenerational ethics and sensitivity towards sufferings of everybody, not only human beings, but also animals. And she said that she lamented the fact that economy is always favored by the climate is treated as a rumbling ant. And she also talked about the mental health concerns in the any kind of a disaster, especially the chronic stress condition, post-traumatic stress disorder, and exacerbated poverty. And that is why she also emphasized the need for a very intersectional approach. Those who are more vulnerable and who face multiple marginalities, they face far more harmful impact of the climate change and any form of disaster, whether it is a health emergency or deluge or things like tsunami or Katrina. And so many times it is the elderly person with disability, LGBTQIA community, trans person, they are the ones. And she gave so many examples of her personal involvement in providing medical care and the health care to the trans persons. And she says it is so important to talk. You can't be impersonal. Just giving a prescription is not enough. You need to understand, and that can happen only when there is a dialogue. And she gave example of her work with the trans persons, and how not only medical care but also understanding there's other social determinants and treating them is very important. And yes, both the days participants active engagement, very rather proactive engagement and sharing and discussing made the whole atmosphere electrified with a very important discussions, as well as so many new issues we also learned from the participants who are professionally very active. Thank you.
Thank you so much, ma'am, for such valuable words. Moving on, I'm delighted to invite our first speaker of the day, Dr. Padma Deosthali ji, Program Director, Creating Resource for Empowerment in Action, CREA, for speaking on the session, Healthcare System and Gender-Based Violence. Thank you for joining us, ma'am. Over to you.
Thank you, Samprika, and thank you, Professor Vibhuti Patel and Dr. Veena Vaswani and the IMPRI team for giving me this opportunity to share some experiences of the work that I've been engaged in terms of improving and strengthening the response of healthcare systems to gender-based violence. May I request the slides to be shared? So, yeah, go ahead. Next. We'll quickly, the time that we have, we will try and look at uncover what gender-based violence means, what is the terminology, the prevalence, health consequences, look at what is the role of health systems, what can health systems do to respond to gender-based violence, and then a few case studies to discuss, what are the issues in the response, if any. Yeah, go ahead. So, you may have heard the term gender-based violence, also violence against women. Often it's used synonymously, but they are not synonymous words. Gender-based violence is a more comprehensive terminology because it includes violence perpetrated against women and girls, sexual minorities, and boys and men. So it's that's something for us to understand, that it's not the same as violence against women. And when we say GBV, it's much more comprehensive. We are covering a lot of other groups. It also includes, if I may bring in here, women with disabilities, and looking at violence from the medical system in terms of forced sterilizations of women with disabilities, forced hysterectomies, a violation of consent. I mean, they just assume that if it's a person with disability, mental or physical, she or he is incapable of consenting, and the medical procedures are always taken, the decisions are taken by the guardian or any other family member. Then also aversion therapy, conversion therapy. These are all, I mean, there is a movement now which is also clearly articulating some of these medical practices as gender-based violence. Violence against women still forms the largest part of gender-based violence. And within that, intimate partner violence or domestic violence in India and Asian countries is something that forms a big chunk. And in terms of prevalence, that's the largest prevalence that exists. Go ahead. So this is just to kind of present before you, I have used the outer circle as violence against sexual minorities, men and boys. The second circle is violence against women and girls, by family, by the state, by community, violence that women and girls may face at workplace from strangers. And then you have the center, which is the intimate partner violence. And or domestic violence, which is the largest. Yes. Why are we talking about the health systems? Because victims of violence may come directly or may be brought to the hospitals. And because violence definitely affects the physical and mental health of any person who has been subjected to any form of violence, whether it's physical, sexual, emotional, or financial. Women may report violence, may not report violence, but they will definitely come for treatment. And therefore, health systems create an opportunity where doctors and the other healthcare providers can identify abuse, treat, and provide psychological support, and connect these survivors to other violence against women services. Go ahead. There's been ample evidence now about the impact of violence against women on the physical, sexual, reproductive, and mental health of women and girls. It is one of the largest killers of women in the reproductive age group in India. Burns, poisoning, assault with knife, abetting suicides, are many other ways in which women are killed, by family members. Go ahead. This is the global evidence on the health impact of violence against women, where they have looked at the DHS surveys across different countries, more than 150 countries that the data has been compiled for. And they have found that women who are exposed to intimate partner violence are twice likely to suffer depression. Okay, they are almost twice as likely to have alcohol or other disorders or any kind of other addictions. It affects sexual and reproductive health, where we find that 16% more chance of women having low birth weight babies, 1.5 times more chances that a woman who is experiencing intimate partner violence is likely to have or suffer any kind of sexually transmitted disease. 42% of women who have experienced abuse, have reported injuries of some form or the other, and 38% of murders of women are by intimate partners. So that's the kind of burden in terms of the health impact. This is measured, prevalence. Yeah. Go ahead. There's a global consensus now that health systems must provide supportive care, which includes, what does supportive care mean? And I believe many of you here are healthcare providers, which is great. So these are based on the WHO clinical and policy guidelines of 2013, which were, as you all know, as health professionals, that WHO issues guidelines through a very rigorous process. So it has, a certain kind of protocol to look at evidence. And then based on that evidence, these guidelines are issued by the WHO. This is also the first time in 2013 that the WHO has issued clinical guidelines. So up to 2013, there was a recognition that violence against women is a public health issue for the health system to respond, but there were no clear clinical guidelines in terms of a clinical protocol of what a doctor or a nurse must do. And I think therefore these 2013 guidelines become very important, because they are mandating that this is the basic minimum standards of care that every health facility at any level of the healthcare system must provide, and every healthcare provider, whether a doctor or nurse, must provide to a woman who has disclosed that she is suffering from any kind of violence. Now, the global evidence shows that if health systems were to provide this supportive care, then it actually contributes to prevention of violence recurrence. So if there's a woman who's come and you provide her treatment and send her back to the same home, it's likely that the violence will continue. But if you provide her an intervention at that stage, there are chances that she is able to stop further abuse in her life. So there is evidence to show that by intervening, you can prevent recurrence of violence, you can mitigate the consequences of violence, and you can also address associated health issues. So she may have come with an injury, but when you actually provide supportive care, you may find that she is also, experiencing and suffering from gynecological morbidity, which she has not reported. So you can also address associated health issues. It also, the intervention improves the capacity of the survivors to stop violence in their life and also improve their health well-being. So there is evidence around this, and that is compiled and based on which these guidelines have been issued. There's also global evidence that the health systems must document violence against women so that we are able to measure what is the health burden of violence against women, and the health system is able to advocate towards a coordinated response with other sectors. Next. In India, I mean, as far as the WHO guidelines are concerned, they provide a policy mandate, but there's also a legal mandate for healthcare providers through various laws. Those pertain the civil law, which is Protection of Women from Domestic Violence Act 2005, or the law that's around the domestic dowry deaths, which clearly expects healthcare providers to record a dying declaration. So it's only a doctor who can, ascertain or assess whether a person who is under his or her care is going to die. And if there is such a possibility, then a magistrate needs to be called so that a dying declaration can be recorded. The Supreme Court has also ruled that if there's no time for a magistrate to come, a doctor can go ahead and record the statement of the woman, which will be taken as her dying declaration. Then the laws around rape and the child sexual abuse all have a clear section on what healthcare providers should do. And now, with the changes in the law after 2012 and 13, the right to treatment, right to healthcare for survivors of sexual violence is well enshrined in the legal system. Next. But there are several challenges as far as the response of healthcare systems is concerned. And, you have had 2 days of, great experts who have brought in and spoken about how insensitive and, gender blind the healthcare system is, and the patriarchal nature of the entire organization of the health system that, has already been laid down for you. The other aspect is that it follows a biomedical approach, the medicine. So they do not look at violence against women as a important issue for them to respond. They feel we are here only to provide treatment. And, there is a certain germ that causes a disease, and these are the symptoms, and this is what the treatment is. So somewhere the violence against women is seen as something which is located in societal issues, not something that medicine can do anything about. Often it's perceived as something that the police system should look into. Why is the health system being asked to even respond? There's also a failure on part of health systems and healthcare providers to understand inequalities within society. So it's, women are not homogeneous. So women may be from the Dalit community, maybe from Muslim community, maybe women who are disabled. There could be sexual and gender, diverse persons. They face very different kinds of discrimination and violence. And the health system often is not able to understand and may perpetuate more violence against, women from such structurally excluded groups. Next. The other biggest challenge is also healthcare providers' attitude, because many of them themselves may have predominant, they may also believe that domestic violence is part and parcel of married life. If she's being beaten, she must be doing something wrong. She may, she should just listen to her husband. There's also this feeling that this only happens in poor households in certain communities. There's this, perception that most complaints of rape are all false. Because rape is physically not possible. You can't, if she doesn't have injuries, then, she has probably consented and changed her mind afterwards. So these kinds of commonly held perceptions about domestic violence and rape are also very often, imbibed by healthcare providers, because they are also from the same society. There's also disrespect and abuse within reproductive health services, violence in labor room, violation of privacy. I mean, I think Dr. Vibhuti spoke about those experiences. So this is the context of the healthcare system, which becomes very challenging then for such a system to sensitively respond to this individual woman who is reporting domestic violence or is coming after an incident of rape. Go ahead. They compounded with these with these kinds of notions and attitudes. Medical textbooks also carry a lot of stereotypes and biases. So textbooks, have a chapter of the forensic textbooks have chapters on rape, which actually describe who are the kinds of women who can resist rape and who cannot resist rape. They give pictures about how do you determine from the examination of the genitals, the vagina, and breasts, whether a woman is sexually habituated or not, which has actually no relevance. But all of this is still part of medical textbooks. When it comes to even burns, there is no mention about domestic violence or dowry deaths. So there's a whole chapter on how to record and document burn injuries, but it does not mention that domestic violence could be a cause. In fact, one classic example which I always share is that the description in the Modi textbook on medical jurisprudence on burns carries this example of homicidal burns, and that is explained as suicide. So they say that if you find somebody, some woman who's brought to you post burns, and she has cloth in her mouth, it indicates that she has committed suicide because she probably didn't want to scream. So the tying of ropes, the cloth being inserted in the mouth are clear signs of homicides. I mean, commonsensically, but the medical textbook actually interprets it as suicide and a woman's resolve to really not scream and not create any problem because it's a clear case of suicide. Go ahead. So the role of health professionals, as mandated by WHO, is to identify abuse based on signs, symptoms, document the past and current episodes of abuse in a medical legal form, provide her with medical care free of cost. I think that's now in India mandated by law, emotional support, and then refer her to relevant authorities. Yes. Next. This is what WHO has kind of concised as an acronym, which is called LIVES. L stands for listen. So listen to the woman who's come to you. Listen to what she's saying. Ask her questions. Inquire about needs and concerns. So, if she's reported domestic violence, she's disclosed domestic violence to you, ask her what is it that you can do to help her. Validate. So don't blame her, but tell her that it's not right. Domestic violence is not acceptable, that you can reach out for support. Enhance safety by inquiring about whether she feels safe going back to her residence, whether she would like to seek any kind of support to keep herself safe. And finally, S is for support, which is to really keep information about available violence against women services ready with you so that you're able to refer her to relevant services. Next. Ignoring violence can actually do harm. And, I won't get into, these slides will be shared with you just to say that if the health system fails to provide, say, for example, post-rape care or address violence against women in family planning or STI, HIV care, it directly results in unwanted pregnancy, STIs, HIV, unsafe abortion, and more violence. If the privacy and confidentiality is breached, it is going to, partners or the family members may become violent. And therefore, the minimum standards that have been prescribed by the WHO to ensure the provision of lives in a private and confidential space is absolutely essential. Next. The other thing to remember is also the limits of the medical evidence, because often medical evidence is almost perceived as some kind of, litmus test that you will be able to determine whether rape occurred or not. But the reality is absolutely contrary to that. Because what does medical evidence in rape mean? It basically means trace evidence, evidence of semen or spermatozoa, blood, hair, cells, dust, paint, glass, lubricant, maybe any kinds of body fluids or saliva. So these are trace evidences. The other part of medical evidence is injuries. So, if there's any use of force, there could be bodily injuries or genital injuries. There could be abrasions, contusions. And the other part is also infections. Post-rape is also medical evidence. So even if a woman doesn't have injuries, but she has a STD, that is a consequence of sexual violence. Now, the limits of medical evidence are such that what you will find on the body of the woman depends on the gap between when the incident occurred and when she was examined at the health facility. So if a lot time has passed, there will be just no trace evidence on her body. If what are the activities that she has undertaken? Has she urinated? Has she, defecated? All the trace evidence is likely to be washed out. If she's taken a bath, there's absolutely no chance you'll find anything on her body. If condom has been used, and perpetrators are smart, so they will use condom, and if condom is used, there's going to be no trace of semen. The nature of assault may also be such, because now the rape definition has been expanded, and it's not just penetrative assault, but it could be non-penetrative assault, which is also rape, and in those cases there's going to be absolutely no evidence on her body. As far as injuries is concerned, there is now evidence globally as well as from India that less than 20% of rape survivors are likely to have any injury on their body. And this is including children. So that's something for everyone to understand, because all of us have notions about rape and we associate rape as something which is going to cause some kind of injury on the body, but it may not, because rape is, act of power. And therefore, there are, the perpetrator uses that very effectively to completely, create a situation where the woman or the girl is in no position to even resist. So, she may just become very numb, or she's scared and she's not able to resist. And every act of resistance may not result in a physical injury. So this is just for us to, bear in mind that no medical evidence does not mean that there was no sexual violence. Next. Evidence from the ground, and this is work of Dilasa for the last 24 years, the Dilasa intervention that is led by Sehat and the MCGM in Mumbai. And the evidence shows that for young women. So a large number of women who are coming to these Dilasa centers and departments are identified when they come for their antenatal care. So, pregnancy does not protect women from violence. And in fact, violence in pregnancy has been reported by a large number of women who are registered at Dilasa, almost 72% women. Early identification is another evidence that emerges over the years, where most women coming to the Dilasa departments have come within 2 years of the onset of abuse. So if you compare it with women who are coming to the police stations, you find that women may report to the police much later, after the abuse has escalated and they decide that, they want to stop the abuse in their lives. Attempted suicides are something that the health system is able to respond to if it is sensitized to gender-based violence, because these are all recorded by the hospitals as accidental consumption of poison, but they're actually attempted suicide. And 20% of registered cases at these Dilasa departments are attempted suicides. And it provides an opportunity for suicide prevention and violence against women intervention for women and girls. Next. To conclude, a sensitive response by health professionals aids the healing of survivors. Responding to violence against women must be integrated at all levels of the health system. And explanation for absence or presence of injuries and evidence can be key to accessing justice for survivors. Next. there are some pressing issues which are really, because of the law and the demand for justice and more stringent punishments and all of that. We didn't have mandatory reporting laws till 2012-13. And this is not just the case of India, but when we did a review of laws in Asia Pacific countries, in the last decade, all countries that have made any amendments to their laws around violence against women have brought in mandatory reporting. So there's this feeling that and mandatory reporting is actually a huge ethical issue for health providers, because the person coming to you is coming to you for treatment. But the law expects you to report to the police when she or he is not willing to take any step. And it's really against their agency, against their wishes. And sometimes it actually has resulted in denial of services, because they will just leave the health facility moment they know that, there's mandatory reporting here. Informed refusal, just as informed consent is something that is understood as seeking consent, then a person also can refuse, right? And that is what is informed refusal. But that requires very high ethical practice and not really defensive practice. And because mostly it's, in the health system in India is extremely defensive, it becomes very difficult for doctors to, take that position. Married women reporting marital rape, the law does not look at it as an issue or as an offense, but health systems actually can provide the needed care and also carry out proper documentation. Transgender persons and boys report domestic violence, but there needs to be more of awareness so that they are able to access these services. I end the short presentation and we can move to the case studies. Go to the first one, Samprika. Yeah. So these are, we could take maybe if anybody has any clarificatory question, or I'll read this case study and you can respond to it in chat, or maybe just raise your hands and we will come to you. So this is a case study of ABC, who reports to a doctor during her antenatal care that she sustained those cigarette stub burns and scalds as a result of constant abuse by her husband, who was pestering her for a male child. But the doctor ignored it, as she felt that she should only be concerned about ANC. After a few months, ABC attempted suicide by use of insecticides, unable to bear the abuse. What do you think was the role of the doctor? May I request the participants to raise their hands?
You can unmute and speak.
Yes, Bhaviji, please go ahead.
I think the first thing is that the doctor should have really looked into the burns and the scals and have seen if it was a sign of abuse, should have checked up with the patient first of all. Second of all, because they are a point of contact in terms of care, they should have probably also directed them to services or people or resources that could help them with their situation, fully understanding that there's a possibility that this person is going through abuse. And if that would have happened in a timely manner, perhaps they wouldn't have attempted suicide. This is not to say that the doctor is to blame for the entire suicide or the way things have happened, but definitely the doctor could have, the doctor had the power to prevent it at least.
Yeah, thank you. Anyone else wants to add to this?
Aishwarya ji, you can go ahead.
Hello. So
Yeah.
in such cases, I feel doctor is the only point of care. In many times, women speak to doctor only, mostly obstetrician. So and many times the situation at the home is not like the woman can take stand for herself. But in such cases, at least a doctor should understand what she is going through and have the friendly rapport and talk to her about how her safety is important, even though she doesn't want to fight with in the house or don't want to go do legal case. At least it's important for her to take care of herself, to make herself safe, and slowly with the follow-up visits doctor can win her trust, and slowly he or she can make her aware about her rights and what she is going through to understand. Also provide her care in the form of counselor, family counselor, who can go visit her home and talk with the family, and slowly we can win her trust, and we can make her aware about what she can do, because many times the situation is very messy and we can't make herself to go against her family members. So such issues have to be handled very patiently, and not crossing her boundary, not violating her privacy. So we have to handle such things cautiously. And also we can provide her emergency number, that when she is stuck in some problem, then where she can contact. If she is feeling some emotional trauma, where she can call, at least as a friendly support. So these all information we can provide, and just wait for when she's open up fully like that. Yeah.
Yeah, thank you.
There's one
Lakshita
more raised
Singh.
hand.
Lakshita Singh. Lakshita ji, you can unmute and speak.
Yeah, hi, am I audible?
Yes.
Yeah, so I just wanted to say that understanding the plight of that woman and just go beyond being the doctor and beyond being doing her doctor duties would have helped her and improved her situation as well.
Okay.
So
Yeah.
just it would
Thank
have
you.
helped her. Yeah.
Yeah. Thank you for the responses. And, you know, what you all have said is absolutely, you know, on point. And I just want to reiterate that when there is a clinical responsibility or a clinical protocol that a healthcare provider has to follow, therefore it doesn't mean the person is going beyond his or her duty. It's part of a clinical responsibility. A patient has come to you who's, you know, you for ANC checkup, and these injuries, burn and scalds, are signs of abuse which need to be picked up. You need to ask, and here is a woman who's telling you. So once she has told you, then it becomes a clinical responsibility to ensure that you know, it's not like you're becoming a counselor or you're intervening in her life. You're intervening as a person who is concerned about her care and well-being. And I think that, you know, just to, so very well said in terms of what they could have done. And yes, the idea here is not to blame the doctor. And even after intervention, it's possible that the abuse may not stop, and she may actually attempt suicide. So it's not to, you know, say that the attempted suicide was a result of the doctor's negligence or, you know, non-intervention. But the point is that it's a clinical responsibility, and therefore it becomes important that you pick up, that a doctor picks up these signs and intervenes in time. We can move to the second case study. So BCD is a 17-year-old illiterate girl child with physical disability and is brought by her parents as she's pregnant. The parents are construction workers and are at work the full day. Based on a discussion with the parents, she was sterilized without her knowledge, and this was suggested by the health system as a way to avoid unwanted pregnancy. Do you agree? And what do you think should the doctor have done?
Aishwarya Rewardkar ji. then Shobna ji, you both can go ahead one by
Ma'am, can I talk? I'm Shobna Karthikeyan
Yes,
here.
sure.
Can
Yes,
you
sure.
yeah, and sterilize.
Ma'am, sterilizing a person without her knowledge is absolute violation of her human right, of her choice. So, I mean, the system here is getting into her choice of womanhood, motherhood, whatever. So, I mean, moreover, it's an important point here that the girl is only 17. So that's one more thing that needs to be looked into. So of course, the parents are away and all that. Here again, I mean, more, of course, we are talking about people who are construction workers, they're illiterate, and most of them are probably do not have no more than 5-6 years of formal education. All that said, still some channels of communication would be better. I mean, counseling the child as to how to be careful or something would be fine, but definitely getting into this bizarre step of sterilizing the child actually without her knowledge is an absolute no. That's my primary initial response to this question, ma'am.
Thanks, Shobna.
Aishwarya ji.
Yeah, it's absolutely violation of human right. It's against the autonomy of her body. So yeah, obviously it should not be done.
This has happened in a rampant manner in a sugarcane areas, no, where even 12-year, 13-year, 16-year-old girls are married off to mainly because there is a Jodi system in sugarcane. This thing because man cuts the sugarcane and woman has to load and unload, and that is
Yes.
why we have seen it is happening in a big way. Unless you produce the certificate of not only sterilization, hysterectomy, you
Hysterectomy,
don't
yeah,
get employment.
that's very common in sugarcane workers.
Yeah. So, I mean, Aishwarya and Shobna, I mean, thank you for responding. And I think, yeah, anyone would disagree that, this was done to this girl.
Bhavi wants
But
to
what do
speak.
you think the doctor should have done?
I had
That's
a
the point.
doubt though.
Yes,
I
yes.
don't have a contribution. I have a question. So, because you mentioned that the age is 17, this now becomes a unique case in the sense that this is not a person who's legal yet. Like they're still considered a
Fine.
child, technically speaking. So then we can also say that because it's a person with disability and it's the parents who've done it. So what is the defense here really? How can we defend it? Because at the end of the day, for a child, it's always a parent who makes these decisions because they don't really have a voice of their own, at least not till 18.
Yeah.
So how is this dealt with in a legal manner?
But it's also happening in the shelter homes, no? A person with disability. It is there was a big controversy also about
Right.
all menstruating
Hysterectomizing
girls.
all girls with intellectual disability because they can't manage menstruation and therefore they're all hysterectomized, which has been questioned and you can't do that. But the point here is that it's a child who has probably been raped, or we don't know, like, we don't know from this description, but even if it is consensual or she has been raped, that trauma has been left aside and a solution has been found that in order to avoid, so the only, had it not resulted in pregnancy, probably the parents would never know that this was happening. So it's also about what, like Shobna said about how do we communicate with girls with disability about good touch, bad touch, about safety, how to keep themselves safe. So I think that's something that needs to be also addressed. And this thing that the only way out is then to sterilize her. So in that sense, we are just kind of, saying that the abuse can continue, but she won't get pregnant. So, all those issues in terms of intervening, especially with somebody with disability. So, bringing in people. So, we've not said what physical disability. So, if communication is possible, otherwise bringing a special educator who can communicate with the person, explaining, seeking history about what has happened and not just solving it by sterilizing. And now we have the Rights of Persons with Disability Act, where any reproductive health related issues must be done with the consent. And you are right, Bhavi, that the 18 years and the parental consent, but there is now, I think, a recognition that we must speak to the children and also find out what is it that they want before taking these decisions. Such decisions can even be postponed, even if there is a very pressing medical condition, and but for this particular case, I think what I really wanted to emphasize was the abuse, and that being completely sidetracked, and a solution being found, which is sans any kind of intervention to keep her safe in future. Yeah, we can go to the third one.
Also, just I want to add one thing.
Yeah, please.
Even if there can be another angle that the girl is sexually active, maybe it's not an abuse.
Yeah.
So the parents want to control her sexuality.
Exactly.
You are not physically
Exactly.
able, so the physically able people doesn't have right to express the sexuality and get pregnant and all. So that's
Thank you.
another.
Yeah.
dimension.
Thanks for raising that. And that's not just the parents and society, where they assume that women with disabilities are incapable of having any kind of sexual pleasure, or you are disabled, you can't have any kind of sexual urges or anything. And
Yeah.
also that they're incapable of becoming mothers, so they cannot
Yeah.
reproduce because you're disabled. So thanks for bringing that point in. And yes, this is a way to really control, her sexuality, mobility, all of that. Yes, thank you, Aishwarya. So case study 3, Mrs. L reports to the doctor that her husband forces himself on her every day. All efforts to escape from his sexual violence has gone in vain. Of late, he even pushes his fingers and sometimes even sticks into her vagina and anus, which has resulted in pain, bleeding, fissures, and warts in those orifices. She has now reported to the doctor for both treatment and advice to stop this violence. What should the doctor do?
There's a raised hand by Shobna ji. If you want to go ahead, please.
Actually, I'm not yet ready to answer this. I just did not lower the hand that I had raised last time. Sorry
No
about it.
problem. No problem. Take your time. Anyone else? Yes, Bhavi.
I think first of all, it needs to be documented so that regardless whether she wants to take action right now legally or not, some documentation is ready, first of
Yeah.
all. Second of all, that documents, all of those proof need to be kept confidential and those cannot be breached. Third of all, treatment immediately and also connecting them to resources to prevent this kind of violence and to get them out of the situation. Now, we don't know what kind of a relationship or what kind of a person the husband is. So we don't know what we are dealing with. We can't force them to act immediately or do something a certain way. Of course, they will have their own freedom and choice, but definitely the person has to be counseled on all possible options and what steps they can take and the resources. And I do think that hospitals will have some sort of social workers or some sort of contacts for something like this, so they have to be sent to those departments.
Hospitals have medical social workers and psychiatric social workers. Number one. Number two, why do we need documentation? Her testimony, isn't it enough?
It is enough. However, we don't live in a society where people believe women. Now, see, if
I'm talking
we
of
are raped,
criminal
for
justice
example,
system, only criminal police and court.
that's easy to say right now, but the problem is that people don't believe women. It's a sad reality. People don't believe women. And if she needs to get the justice that she deserves, it's better to be safe. I know that this sounds very crude and rough, but it's the sad truth, because personally I've seen it, like even with the the dog rescue cases that I do, I always capture proof, because I know that if I had to take a stand somewhere and I'm questioned, I'm always ready with some sort of backup.
Yeah. Yeah, thanks,
It's very
Bhavi.
sad because people will believe men when they say something has happened. But if it's a woman who's claiming something has happened, she'll always be questioned. She'll be called a liar. She'll be dismissed. And so having proof is always helpful. Although it's sad that that's the reality.
Yeah. That means only medical examination, no?
Yeah, only medical
Or
examination,
medical
Vibhuti,
proof,
she
like
said.
whatever. So they've mentioned bleeding, pain,
Yeah,
fissure
yeah.
spots. So those.
Okay. Oh, yeah, that is fine. I
Perfect.
put the picture of the private
Yeah.
parts. Okay. Yeah. Fine.
Any,
Medical examination.
anyone else would like to add to this? Yes,
Can I
Alicia.
say something? Yeah.
Should I go ahead or Professor Vasani, of course, if you want to go interject, please do.
Professor Vaswani, would you
Can I
like to
say
go?
something?
Yeah, please.
Because she is the forensic expert. She's
Yes,
in
yes,
those
yes.
states. Yeah.
What the discussion is going on is very interesting, because whenever it comes into a path of possible criminality which is to be used later, it falls apart miserably, because no amount of scars will support you, but the documentation at that time does. So in fact, even as much as even if they have put her to burn or they have tried to do anything, they're just not eyewitnesses sufficient. You'd have to have a medico legal case, and that is also a double-edged sword, because
Correct.
sometimes when they have patched up together, the case will come to haunt them if it's a criminal case.
Yeah.
And then most of the time when it is not such a cushy situation, not so good situation,
You're on
believed
mute.
at all. Me? No? Can you hear me?
Now we can.
Yeah. So the question is, because nobody believes her, so same in the court, no amount of most sincere expression is going to help her out. So I think it's a bit bad situation, because once you make it medico legal, especially I think I like Dr. Padma saying that I'm very passionate that all the abused children should not make it medico legal as a mandate, because they fall out through the safety net of healthcare.
Perfect.
We had so many times
Yeah.
abused children come to us, and many a times postgraduates enthusiastically go and make it medico legal, make it police case, and then they run away. So the children are in the danger because they won't access healthcare.
Correct.
So that's very true. So I really like that point. So thank you.
Alicia, do you want to come in?
Yes, sir. What I was about to say is, very linked to what Professor Vaswani also said, and I think Dr. Padma, you have given, I think what I think is the solution in your earlier presentation itself, that definitely there are medical and legal routes, but as the first reaction, I think the doctor needs to do is what you said, give the patient all the options, explain what the support systems available are, explain what the legal and medical procedure will be, just so she has all the information, because a lot of time women, children, even men for that matter, don't know these things, and we as professionals, I think we owe it to them to first give the information, check what is their support system. If this particular lady, Mrs. L, has to leave this person, does she have a family she can go back to? Will they accept her? Will they support her? She should not become homeless because of this situation. If there are children involved, then that also is a big consideration. So definitely there are routes to pursue, but the first instinct should always be to take the consent of the
Yes.
victim before proceeding forward.
Thanks, Alicia. And I think Bhavi very well captured what the doctor needs to do in terms of documentation, and very well, Bhavi, documentation, medical documentation. That's very important, because that she can use whenever she wants. It's there on record, as Professor Vaswani clearly pointed out. I just want to say that this narration is a narration of marital rape, which falls out of the criminal justice system currently, but the domestic violence law recognizes this as a form of sexual violence. So documenting it and connecting her to services and providing her support is absolutely critical for the doctor to do. Rest, what she does with it, whether she files a case, not that's a secondary thing. But in only giving her treatment without recording all this that has happened in her life would be gross injustice, because we would fail in our clinical responsibility in this situation. So thank you. I'm mindful that it's 7. What we could do is, there are 3 more case studies. We could share them with the participants, Vibhuti.
Yeah.
And my email ID is there. If anybody would like to, if you have any questions around those case studies, feel free to write to me. So we can stop here. And thank you very much for participating. And it's been a great honor to be part of this course. Thank you again.
Thank you so much, ma'am, for such a wholesome discussion on such pressing issues. I will now like to invite the chair, Professor Vibhuti Patel, for a remarks to the session. Over to you.
And I think Dr. Vaswani should also speak. And the most important aspect of Dr. Padma Deosthali's presentation is the processes which are involved, and which is very important, because mobilizing public opinion, the same reality was there in 1980 when Mathura was raped. And that time also they said that there were no bodily injuries. So the issues were the same, but that time the agitation, propaganda, and mobilization on the street took place. Now we have reached a stage where understanding of the feminist movement, gender responsiveness, medical system, as well as the legal system, both are responding to the demands which were made by the so now there are one-stop crisis center, there are hospitals which are responsive to the kind of gender-based violence that women and sexual minorities are facing. And that is why it is very important for us to understand step by step what we can do as citizens, as persons in healthcare system, nurses, doctors, and also the hospital administration, because these are now we have a legal mandate. There is a support by the criminal justice system. So processes are extremely important, and the response of the Dilasa model, now I think we see more and more states are agreeing to this kind of convergence of various services to support survivor of violence. That's it. Dr. Veena? Yeah.
Yes, ma'am. Yeah, I totally endorse what you said, that there are positive role models as well as the Dilasa like NGOs who are working, putting things in perspective. But in the interim, till then, what is happening in reality is if we do not have a proper services, even if it is an abused child, even if the wife is ill-treated at home, subjected to violence, and then there is no other reprieve for her, because the alternates that we offer are not actually acceptable in a way that they're secure, they're safe, they provide nutrition, they provide some kind of consolation or this thing for them. So that is why, because even when I see children of abuse under POCSO, okay, it's all fun to say that, okay, POCSO is doing really well. It is doing well, but to what extent? What do we have for children? Because last time when we reported a POCSO where a girl was systematically abused, she was barely 7, and she came from Bombay because she was abused, but somehow people came to know that this is a child worth abusing or whatever. And again, the same abuse started. So we are struggling to get her, but then when we call the Women's Social Works Department, they are telling that she's better off in her place. We cannot offer that kind of security and safety. So then actually, although there are provisions are there, the leadership may be lacking at places to make it work. Because I often feel when we look at corruption index and the way we are sliding down, that it's not just the policies. It's good to have policies, but to execute it, do we have an honest, sincere system to make it So that is where I think we citizens can play positive role in trying to raise our voices to see the systems are in place.
Yeah.
Thank you so much.
Thank you so much, ma'am, for such wonderful remarks. Now, I would like to say that the floor is open for questions from the audience. You can write your questions in the Q&A box or raise your hands and ask your questions.
Speaking from a career path, perhaps to understand what kind of things are available and what kind of roles could be taken up, what kind of path does one need to take in order to change policies, say for the forensic aspect, in terms of collecting evidence or in terms of looking at the situation and understanding because as an engineer I see that there's a lot of improvement in tech, but I'm not seeing that being translated to the legal system. So how do you connect the tech and the legal system such that we are able to translate it?
Okay, ma'am, can I answer?
Yeah.
Yeah. Okay, so if you're asking me as forensics, I can take examples of countries that progressed in judiciary, in legal way, in investigative, when they looked at forensic science, forensic medicine, legal and political police on the same lens, that all the three need to be strengthened. Whereas I think we doctors in India have a bit of ego, that we don't like to rub shoulders with investigators, police, lawyers, or judiciary, and we think we are a class apart. Maybe it's my prejudice, maybe it's my bias, or it's my experience from the part of world that I've experienced. Whenever we come together on the medical legal setting, we are always fighting. We are pointing fingers at police saying, you're not good, you're not very, time conscious, you're not having integrity. We look at forensic science and say, you don't deliver on time. And we look at judges and say, no, they are not updated, only our knowledge is updated. So somewhere I think we should make up our minds that we are not the only person who have a big ego. And similarly, they also work with their ego. And the only victim out here is justice. So if we make it a point to say that we need to come together to build trust and work towards a common goal, only then the justice will be served. Because especially in departments like ours, which require the help of others to dispense justice, to disseminate justice, we have to cultivate a professional trust. And we can't work in silos like we are doing now, a watertight compartment. I'll do my best, I'll give my report only to the court. That's it. I don't talk to the family. I don't talk to anybody, nor do I ask convincing report from the police or advise them or say, I'll come with you. Let us see how we can do it. So somewhere that leadership, we are a little short on that. So that's what I think of it. Yeah. Thank you.
May I respond, Vibhuti? Yeah. So thanks for that question. Thanks, Dr. Vaswani, for putting it so straight. Just want to say that Vibhuti spoke about the Mathura rape case in 1972 and the entire movement after that, in the way the medical evidence was interpreted by courts and the way medical evidence was documented. And things have changed. It's not as if we haven't made progress. In 2013, after the Nirbhaya case, there was a petition that was submitted to the Government of India and the PMO office, which was about banning the two-finger test, and over 100 doctors had signed it. So I'm just trying to place that there is a recognition that a lot of this evidence collection and the forensic practices are archaic. They need to change. 2014, we have the ministry guidelines which have actually decoded the medical evidence in sexual violence very clearly. In fact, they are titled as guidelines and protocols for medico-legal care. Yeah. And there is an emphasis on care there. It's not by accident that you have guidelines for medico-legal care and not medico-legal documentation, because it was to emphasize that it's not just collecting evidence, but also providing treatment. So I think there's been progress. The medical jurisprudence, the Modi's textbook, the rape chapter has been rewritten, but other textbooks have not followed that chapter, those changes. Those need to be updated. So just want to also leave with some good examples. And I think one of the papers that's been included in your compendium is around what has changed after, criminal justice and the entire changes in law in 2013. So I hope you find that useful.
And
Thank you.
I think we need to strive to have it in the academic training, which all the judges and police and all, they have to regularly undergo refresher course, and all the new laws, they need to keep themselves abreast with. So I think in that, the syllabus also, we should see to it that these topics are included. No?
Yeah.
Which was done because women's movement was very vigilant during 80s. We saw to it that in all the, whether it was the training for judges or for police or for administrator or bureaucrat or district magistrate, everywhere the training modules were prepared, and they were, now it has stopped, and that generation is now retired also. So now the new cadre of the state administration governance structure, they need to get oriented towards these issues. It should be part of the syllabus.
Seeing no more questions, I think we can move on to the next session. If that's all.
Thank you.
Thank you. Thank you, Dr.
Thank you once again, ma'am, for such an interesting session. It was a pleasure learning from you.
Yeah.
Moving along, we have our second session of the day on healthcare and gender, advancing systems, structures, and policies to address challenges faced by queer community by Dr. Aqsa Shaikh, Associate Professor, Community Medicine, Hamdard Institute of Medical Sciences and Research, New Delhi. However, Dr. Aqsa Shaikh won't be joining us live today, so we shall be playing a pre-recorded video, and the questions thereby asked shall be sent to the concerned person with the best of our endeavors.
Yeah, and I think Dr. Veena can also answer because Aqsa Shaikh is a faculty in her center. So, yeah.
I hope the yes. So we need to first of all understand that gender diversity is a concept that still a lot of people do not understand. It's still being debated whether we speak about trans people entering women's sports, whether we speak about gender reassignment surgeries, or we speak about the debates on reservation for trans people. It's still a topic that our society has to come to terms with. And what we don't understand, we start fearing, and we often are afraid of trans people. And then they are judged as evil, as bad people, as sinners also. And then what we judge as evil, then we start to control, we start attacking, and that is how transphobia, homophobia, and various other forms of hatred that we see come up. And we also need to understand that in terms of intersectionality, trans people do not exist in isolation. They're not just trans, but they also may be following a religion and face marginalization on account of that. They may be a Dalit trans person, they may be a trans man or a trans woman, or a non-binary person. And then there are also other intersectionalities in terms of class, region, tribal identity, and so on. And somehow there is a lot of interaction that happens between gender identity and healthcare. When we speak about intersex people, for example, I'm sure this must have been discussed by now, that what's the difference between trans and intersex people is that intersex people are those whom you cannot put into the category of either a man or a male or a female at birth. We sometimes say ambiguous genitalia, sometimes it's called disorders of sexual development, which is not a good term to use, and we can say differences in sexual development. And right from there, the intervention of healthcare workers in the life of an intersex person starts. When it comes to transgender people, once they start having, a realization of their gender identity, and gender dysphoria kicks in, that affects your mental health. And then you need a healthcare provider to, provide you help to deal with this gender dysphoria. So, there's a lot of close connection between gender identity, between sexual characteristics, sexual orientation, and healthcare provision. And unfortunately, it's a difficult relationship, I must say. Now, before I go and talk about gender diversity and especially about trans persons, I want you to have an image. And look at this image, and this is the image that we generally associate with trans people. Also thanks to our media, and this is possibly the most visible form of trans people around. But I also want you to understand that there are also trans people like this. We have trans men or trans masculine people. And we also have people who are non-binary or gender non-conforming, who do not identify with the binaries of men and women. So when we speak about different gender identities, then not just three, but beyond these many gender identities is what we need to keep in mind. And though we say that it's a minority population and our census has measured it at around 5 lakhs, I would say it's an undercounting, understatement. And probably the actual number of gender diverse people may be 10, 20 folds higher. Unfortunately, we are not doing a census now. We don't know when the next census will be done. And, as it was mentioned, probably you might have seen it in the movie Tali also, is that maybe in our cities, we know the number of dogs, but we do not know how many trans people are there in our cities. And that's really very tragic, because if you are not counted, then you don't count. If you are not counted, then there is no estimate of how to provide healthcare to you, or how much finances to assign, or how many resources to give. A lot of trans people, as you know, do not get access to education, especially since trans identity, starts kicking from the age of around 3 to 4 years, which is also the time when you're entering schools, and therefore you have a very high chance of getting bullied, or maybe even abused. And therefore, the opportunities at education are very few. And therefore, a lot of trans people engage in traditional professions. This is not begging. It's called Basti Badhai. They may also be involved in sex work, or they may do performances like dancing, blessing, etc. And as you know, for a very long period of time, trans people weren't recognized legally in India as a separate gender identity. We only had 2 gender concepts, or 2 sex concepts rather. It was the Nalsa versus the Union of India judgment by the Supreme Court, which for the first time recognized trans folks as the 3rd gender and talked about their rights. And those rights also included the right to healthcare, discrimination-free healthcare, and accessible healthcare. And there have been now a lot of landmark events, starting from 2014 with the Nalsa judgment. Then the Indian Psychiatric Society's position statement came, which said that sexual orientation and gender identity cannot be and should not be changed, and that these are not diseases. In 2018, the landmark reading down of Section 377 came. 2019, the Trans Persons Act came. Then 2020, trans rules came. And remember, this was all happening when the pandemic had also struck us. In 2021, the convergent therapy was banned, again thanks to another High Court decision. Then we had the health insurance launched for the trans people by the government. And now in the MTP Act, it talks about trans people also, and not just women, as traditionally mentioned in the Act. And there have been, I would say, a lot of, small incremental progresses that have been made in terms of healthcare for gender diverse people. The courts have taken a very stern view of the queerphobia that is present in our medical education, and the need to revamp that and Fortunately, the National Medical Commission has started that process by changing the curricula for 2 subjects at least, that's forensic medicine and psychiatry. So you might have heard about this, that terms like sodomy or lesbianism have been removed, and there is also, for example, there was a question about the 2-finger test, and that's also removed from the curriculum. Then we had this in the same judgment, the Madras High Court saying that convergent therapy, the National Medical Commission needs to do something about it, and then National Medical Commission said that it will be a professional misconduct. But unfortunately, when it comes to healthcare delivery system in India, it's a very complex mesh. If we think that only MBBS doctors are providing healthcare and trans people are only seeking healthcare from MBBS doctors, then I think we are living in denial. We have Ayush systems operating. We also have unregistered medical practitioners, untrained, unlicensed medical practitioners. We also have spiritual healers, who are treating people, and all sorts of people. But unfortunately, when it comes to the legal application of convergent therapy being a professional misconduct, it's only limited to people who practice modern medicine, or what we call allopathy. If as a homeopath or an Ayurvedic practitioner, I'm practicing convergent therapy, then there is no provision in the law which can stop me. There's no provision in the law which can punish me for that. And it will have to be basically a reading of the judgments, probably in the Mental Healthcare Act, to find a way towards it. But there is currently no law which penalizes practicing convergent therapy. And recently there was a documentary that was published by a journalist who came from UK, went to 2 doctors in Delhi, faking herself as a lesbian woman, and she was prescribed drugs worth 15,000 rupees by a homeopath, and promised that within a few weeks her sexual orientation will change and she'll become a straight woman. And unfortunately, the National Medical Commission's hands are tied, and it said it cannot do anything because the person is practicing homeopathy. So these are the kind of challenges that we are facing, and the things that we need to see in the way forward. While we speak about progressing and providing quality, equitable, inclusive healthcare, there are certain things which are really shocking, and one of them is that trans people or men having sex with men are permanently deferred from donating blood. And there is a case that's going on for that, and our government has said that there's scientific evidence to prevent trans and gay people from donating blood. That being that they are at a higher risk of HIV, and therefore they should not be donating blood. Of course, when we look at the ethics of it, when we look at the risk-benefit analysis of it, when we look at the stigmatization that a community may face because of such things, then that is something that we need to discuss a lot. I can speak for half an hour on just this topic of blood donation ban on trans and gay people. But then we need to question, do we have technology that can detect HIV in the window period? Can we really look at people and do a better counseling and find out those who may be in the window period or who may have had an unprotected sexual act? Do we need to put all people together and say that all trans people are at a higher risk of HIV? There are many trans people, for example, who are not into sex work, who may not have multiple sexual partners. A lot of trans men do not engage in penetrative sex. And therefore may not be at a higher risk of HIV. And therefore, it really, it seems the question is it just be convenient that, okay, we say all trans and MSM, higher risk of HIV, and just ban them? And that thing can cost someone their life, because when it comes to trans people who live within the Gharana systems, who are not part of their families, they don't have friends who are out of the trans network, from where will they get blood in the case of emergency when they need blood? It's the people from their network who are going to give blood, but unfortunately NAPO says that they can't donate. So these are the kind of questions, tough questions that we need to ask. Now let me take you through some of the broad dimensions of trans people and their need for healthcare. I'm making a statement here that trans people have a higher need of healthcare. But at the same time, I don't want this to pathologize trans people and say that trans people are diseased or that transness is a disease or trans people are unhealthy. It is our systematic discrimination which has made trans people in need of a higher healthcare. And let me tell you how. We know that when it comes to mental illnesses, suicidal ideation, suicidal attempt, or death by suicide, all of this is much higher in trans people. Not because there is a gene in them which is more active as compared to the others, but it's because like the society, the families, their own parents sometimes do not accept them. And as a coping mechanism, unhealthy coping mechanism, a lot of harmful substance use may be seen in trans people. There can be a lot of self-medication because for trans people, it may be more convenient to do self-medication than to go to a doctor who may be transphobic. And that self-medication can also include doing hormone replacement therapy. Trans men with uterus may have need for menstrual hygiene and may need care for menstrual disorders, but for them to visit, for trans men to go to a gynae OPD, itself sounds ridiculous how men can go to a gynae OPD. Since one of their traditional professions is sex work, then they have an increased risk of STI and HIV. And being low in the power hierarchy, the negotiation power that trans people have, trans sex workers have, can be extremely less. Dr. Padma had also spoken about that. There's increased risk of non-communicable diseases and cancers. Cancers also because of the use of hormone replacement therapy and because of other factors that they may not be having access to preventive checkups like pap smear or mammography. They often undergo gender affirmation services, and for that you need to go to the healthcare system. You have poor insurance coverage. Hardly 1% or maybe less than that of trans people may be having health coverage. And even when we look at the Ayushman Bharat scheme and the TG Plus card, I think not a single person has so far been able to receive benefits under that, not a single person in entire India. Lack of family and friend support is always there, and therefore they build their own networks and gharana systems and take care of each other. And there may be poor awareness and affordability in general for healthcare, which we saw also during the time of vaccination, for example. Now, there are a lot of barriers to healthcare that trans people have, and some of them can be at the level of themselves or at the level of their family. That barrier may be because of stigma and discrimination, which can be sometimes self-stigma and discrimination or body image issues. And I'm using this picture of a trans man and his chest, which has undergone a chest reconstruction surgery. Because when we talk about, men's chest, it is not only, for example, some of our actors who post shirtless pics as the ideal men's chest, but this is also how men's chests look like. But imagine a trans man who goes for cough, cold, and fever to a doctor. The doctor says, for example, to undress. And then the trans man undresses, and then the doctor sees the scars and wonders, how is it? What is it? And then the curiosity goes on another dimension rather than, auscultating the chest of this person. And because of these experiences, or because of the perception that this experience may happen to me, I will not go to a doctor. For these illnesses. There may be past negative experiences that, 5 years back this happened to me and therefore I don't want to go to a doctor now. Or it happened to someone else, a friend of mine I know, and therefore I think it will happen to me also. Who decides for trans person seeking healthcare? Sometimes it may be their guru, sometimes it may be their family members, because in India, power and decision-making works in very curious ways. Especially when it comes to trans people. How many trans people really need mental health care? And if they need, can they decide they want to go? And if they really want to go, can they actually physically go and meet a psychiatrist? And who decides that? These are the questions. You have barriers to healthcare system in terms of no doctors being available who are trained in providing care to trans people. Even if they are available, they're only in the cities. They are not affordable because of the supply-demand imbalance. And then what's the quality of the care? There are many trans people who have lost their lives after gender-affirming surgeries. There are trans people who, because the doctors weren't available or weren't affordable, have gone to quacks or unregistered medical practitioners and gotten surgeries done by them, with disastrous consequences, sometimes even leading to death. There are unfortunately no regulating bodies that regulate gender-affirming surgeries in India. There are no SOPs, and therefore every doctor is free to experiment on trans people with the newer techniques that they may have learned in some country. And there's absolutely no control, no regulation. There are many cases which are pending in the courts about botched up surgeries of trans people, their deaths, or with disastrous consequences. But unfortunately, no real justice has been done. I want to share a recent case without divulging much details. About an intersex trans person, who is based out of a state in southern India, came to Delhi for a surgery, went to one of the corporate hospitals by doing fundraising, collecting a few lakhs of rupees, undergoing a surgery. And then an error happens in the surgery, because of which a stoma has to be created. And now for a trans person who went there for a vaginoplasty with the dream of having a new vagina, and now she has a stoma back. And, that's traumatic for her. And now for the later part of the surgery, again, she has to pay to that hospital, and there is absolutely no acceptance of negligence, or at least the courtesy of giving free treatment now for the next stage of surgery. So these are some of the instances, and these people are absolutely helpless and at the hands of the surgeons. Now, I want to highlight this message that, I know I've been talking very emotional, triggering stuff, but then this is the hard reality of a lot of trans people's lives. And, a lot of people like me and others often feel that, yes, this is pitiful, this is very bad, but what can I do? And I'm only one person, I cannot do everything. There has been hundreds of years of injustice, and what can I really do about it? And I think you can always start somewhere, maybe with something small, maybe with changing your own self, reflecting on your biases, implicit biases, your perceptions. And then that is how the change begins. So let me take you through some of the steps that I propose on how to undo this injustice. First of all, we need decriminalization, depathologization, and demedicalization. Very big in English words. Decriminalization, because remember that trans people had been criminalized under the Criminal Tribes Act in the British India, which was, of course, removed. But still, a lot of trans people are just put up into locker as habitual offenders under the Gunda Act, for example. We know that gay people who engaged in unnatural sexual offenses, especially gay men, were punished under Section 377. Then we had the Nalsa judgment, we had the Navteej Johar judgment, and changes had begun. But still, we often look at trans and MSM as people with disease, and that is why you have the blood donation guidelines, which says that, oh, we can't take blood from you. We still perform surgeries on intersex children, playing with their genitalia, changing their genitalia as per the choices of their parents and surgeons, trying to convert them into girls and boys so that they can have a tick in only one box. And these surgeries are often done for cosmetic reasons, not life-saving. And I'm sure you have read about this judgment where the court said that no surgery for this child because it's not life-saving. And let's have a medical board who will guide on which surgeries are life-saving, which are not life-saving, and who can do them. We all talk about health for all. We all talk about universal health coverage. And it's important to not just look at the numbers, but also the granular data, to look at qualitatives and the case studies. The question that we need to ask is, are we really having health for all? And especially when it comes to health for trans and gender diverse individuals. You know, sometimes when we look at the response of the healthcare system, especially the public healthcare system by the government towards the gender diverse people, you know, we have the headlines coming like, okay, the Ayushman Bharat TG Plus card is being given to people and there is a 5 lakh coverage. Published into hundreds of newspapers, but not a single trans person, and it's been 11 months, not a single trans person has received a single rupee out of that scheme. And therefore, it really is a question is, are we just good designers and poor implementers of the healthcare system? Gender affirming care is still not included into the essential healthcare. The HRT that trans people is not included into the essential medicines list. Trans people still face a lot of difficulty in having mental health care, and we do not have queer affirmative mental health care providers. In fact, just yesterday I was at NIMHANS where we released a manual on queer affirmative mental health care and how that is possible. And I could still sense that, you know, we in 2023 are still talking about, you know, the mental health care needs of the trans and gender diverse people. When are we going to implement that? You know, because our lack of implementing that means that trans people continue to face mental health challenges, and some of them lose their lives because of this delay that is happening in us not being able to provide them healthcare. It's very important to also, you know, provide competent healthcare. India is the country which produces one of the largest number of doctors in the world. We have more than 700 medical colleges, thousands of nursing colleges. But is the curricula of the healthcare systems, you know, queer affirmative? And can just changing the curricula change the thing, everything? You know, so for example, we have now disability inclusive curriculum, which says that for 6 hours, you know, these competencies have to be taught. But when we look at a lot of colleges, actually, they're only teaching for 1 hour, 2 hours, and that too only, you know, on the medical aspects of disability and not on the social or justice or equity aspects of disability. So it's important that, you know, we talk about it. We have the national health policy. We have so many policies, but they hardly speak about gender diversity and the need of healthcare for the gender diverse people. I want to highlight 2 work that we have recently done that has focused on healthcare and gender diverse people. As some of you may be knowing that I was working as the nodal officer of a COVID vaccination center, and we had this endeavor that we must make a center that trans people walk into, feel safe, feel accepted, take vaccines, and encourage other trans people to come to. And we were fortunate enough to do that. And we also studied during that time the structural inequities that we have in COVID-19 vaccination access and uptake amongst the trans and disability communities in India. And we looked at it from a very intersectional approach where trans people are not just trans, but they may be also disabled and having various intersectionalities. It's also important to give control to the communities that we serve. You know, looking at the picture from their perspective, from their lens, from their point of view. And that is why we started this project on photo voice stories by individuals from the trans and disability communities. Through their mobile phone cameras, they took pictures of how inaccessible, you know, these vaccination centers can be. And something that we never thought, you know, even I come from the trans community, but I must say I'm a very privileged transgender person who is part of the healthcare system, and therefore cannot even realize the challenges that probably other trans people have in accessing healthcare. And these photo stories were actually a glimpse into the unidentified challenges. You know, it's not just about a ramp. It's not just about, you know, whether there is a trans toilet available or not. There is much more to it. that trans people face or disabled people face in accessing healthcare. Lastly, I want to say this, that while we are discussing this about healthcare and its interface with the gender diversity and intersectional marginalities, we must constantly keep asking question, are we including them in this discourse? And I'm really very happy that IMPRI has always ensured that people who come from the community are given the opportunity to speak on these issues, and I'm extremely thankful that they do that. But when you go back and do this process of talking about it in other groups or looking at implementing it in your work, in your research work, constantly keep asking this question: are we doing research on trans people, or are we doing research with trans people? We are not guinea pigs. Intersex people, trans people, gay people are not guinea pigs. They are not subjects of research, right? So start doing this. Are we building a new healthcare system with trans people? How do we know what are their needs, unless you listen to the trans people? So nothing about us without us is the dictum that we must always remember. I'll stop here and would really love to take questions or hear comments. Thank you.
Thank you so much, ma'am. I would request Vibhuti ma'am to give her remarks.
Dr. Aqsa, I think Dr. Aqsa's very erudite and sharp presentation has widened our horizons about the problems that queer community faces. Over last 30 years, we have seen individual struggles, pains, torture, deaths, and even during the pandemic, we saw their exclusion. But now one very hopeful sign is that the queer movement and the human rights movement, civil liberties movement, and the women's movement have converged. I have shared a report which was where the testimonies by the trans persons and queer community were given about the familial violence. So now the problem is that protection of queer community and sexual minorities and the gender diverse people from their families. So we also need a law which would protect these children as well as adults from the violence, because they are also deprived of any access to education by their own family members because they throw them out, or property rights or any other entitlements which any child in a binary framework gets. So I think we all, the question of solidarity becomes very important. And I strongly request you all to go through that report, which is based on the first person testimonies of the gender diverse people. It's there in the chat box. You can download it, read it.
Thank you so much, ma'am, for adding your remarks. Now we would move on to the next session. During that time, the participants can write their questions on the chat box that they want to ask to Dr. Aqsa Sheikh ma'am, and we'll be conveying them to ma'am personally, and she'll answer them. So moving on, we have our third session of the day on healthcare and gender equity, perspective of nurses, by Dr. Swati Santosh Rane, CEO, Seva Shakti Healthcare Consultancy, Vice President, Clinical Nursing Research Society, Core Committee Member, Jan Swasthya Abhiyan Mumbai, Visiting Senior Fellow, IMPRI. Thank you for joining us, ma'am. Over to you.
Hello.
Yeah.
I'll just share my slides. Are the slides visible?
Yes,
ma'am. Thank you, IMPRI and Vibhuti ma'am.
Ma'am, you can go full screen. Sorry to cut you off.
हाँ, go full screen.
Yes, 1 minute.
वहीं जहाँ नीचे में थे ना आप मैम, जूम के बगल वाला. हाँ, yes. Yes, please.
Yes, I can't see all them.
हाँ, it's full screen. Please go ahead. Cursor मैम bottom left में.
एक second.
Bottom left में cursor. Left bottom. Yeah.
Okay, 1 second. Is the slides visible?
Yes,
Hello?
makes sense.
Yeah, there is one problem is I can see all the chats on my screen, so I can't. Okay, now it's fine. Okay, thank you, IMPRI and Dr. Arjun and team and Vibhuti ma'am for giving me this opportunity to keep the nurses' perspective on healthcare and gender equity. So nursing, if you see, is defined by various organizations and even in nursing itself, we have International Council of Nurses, WHO. And when you see these definitions, I'm not going to read all of them. What I want to tell you is that nursing is defined by various organizations, nursing professionals, and also WHO. And what we see is that the definitions are changing. As the nursing itself is evolving, we can see now advocacy, promotion of safe work environments, research, all these things are being added. And historically, if you see if I pick up from what Dr. Jasani had told us, that nursing was always there, but unfortunately or fortunately, nursing was not given that much of importance because of the female domination. And also, historically, if you see the healthcare system as it started becoming more and more systematic, and in a place like hospital where the domination of male came in, the nursing, which was actually a care part given by the women, became more of a non-dominance and more obedience, and which we can see also in the education system of nursing, where it has been seen that nursing education itself has been trained to be more obedient and subservience, and the voices of nurses was never heard. But I think pandemic really brought a lot of change in nursing, and advocacy term was very much highlighted, though advocacy term was included in the profession's code of nursing by the International Council of Nurses in 1973. The challenges which we see in public hospitals of India are not different than what we see in government, non-government hospitals or private sector. But let us first understand what the organized sector. Public health hospitals are much organized than the private health sector, which is not, I would say, is organized. So the nurses' work is challenging and complex. And top it all, in the hospital itself, it is more complex because the hospital structure itself is very complex. Why the structure is complex? It is complex because we have got variety of disciplines, specialities, variety of professionals. Not only do we have doctors, but also we have administrators, we have got technologists, we have got nurses, we have got now in the corporate hospitals, if you can say, we have got administrators and management. So the whole ball game is very complex. And in that, for a nurse to work more easily is very much challenging. Understanding the role of nurses is important, and it's difficult to define as it's not clearly mentioned in public run hospitals. During my PhD, what I saw was the last upgradation was done in 1963 of the public hospital job role. And now the work has been started in 2021, and it is about to complete. So you can see the job role itself is not clear in the organized sector. Nursing administration is a neglected discipline in India because nurses were always thought to be giving caregivers, and the academicians also were focused on the clinical nursing part. They were never interested in research, or they were never interested in nursing administration or anything related to policy. Nursing healthcare work environment offers an opportunity for professional autonomy. Yes, we are coming under, we are licensed, nurses are licensed professionals, and they come under, the act is now abolished. We are coming under the commission. But if you see that in the hospital itself, it is not so well seen in the nursing work environment. They are not seen as licensed professionals as the doctors are seen. Nursing staff compromise on various things, which include working condition, facilities, socio-psychological support to manage just day-to-day work, their work efficiencies, their performance, satisfaction, and what Dr. Jasani had mentioned, that nurses are still under the wings of the male doctors or the male management. Organizational commitment in public hospitals is yet to be taken seriously, because we can see that, there is no such thing as budgets for nurses in public health hospitals, and even the care aspect is not taken so seriously. There is the next thing which I want to talk about is men in nursing. So the perspective is that male are not so much welcomed in nursing by the administration, because if you can see in July 2019, the central administrative body of All India Institute of Medical Sciences introduced a gender-based quota, where the males were given only 20% of positions and the women were given 80% of positions. And this was a main issue for the male nurses, that where is why is this bias, and why are we not treated as nurses? Why are we called as male nurses? Why can't we be called as only nurses? And here the issue has started again. In nursing, there is a gender stereotype. Recently, we had a National Nursing and Midwifery Commission bill, which was passed by in 2023 with the dental bill. And the most important part, what we have to see is that the nursing bill, they never called for consultation of the nurses. The nursing bill was posted on the website of the ministry, and the nurses got the message on WhatsApp from the ministry, which shows that how disorganized and unimportant the nurses were treated. And when we had only around 20 days to work on it, and we all nursing leaders tried to bring in the nurses all around the country, which was very difficult. And not only the nurses, but also the nursing allies, the doctors, the sociologists, also the civil societies, who understood the importance of the work of nurses. They wrote to the ministry that why are you not giving us time and why are you not calling for consultation? But this was not at all taken into consideration, and the bill was passed. Unfortunately, the most important part, what one has to understand, that nursing and midwifery are two different disciplines. The skill sets which are needed for a general nurse and a skill set which is required for a midwifery nurse is completely different. But they have clubbed here. The nursing practice is not at all very well defined in this. Only nursing education is defined. So the nurse practitioners program, which is now which has already come in, there is no way that a nurse is a licensed practitioner. So how is this bill going to help the nurses and the society is a big question mark. If you see, this is the thing what we tried to understand, the gap. Okay, so Indian healthcare sector itself is having lot of challenges. If you see the organized sector, that is the government sector, where the things are in place about the recruitment laws are there. There is a way where the structure is being formed, but the structure is never updated. So you can see organizational structures. There are infrastructure issues, infrastructure in the sense of the buildings where the nurses stay, the hostels, the nursing hostels, the nursing schools are very bad in the conditions. Most of them are having leakages. There is no water. So nurses are staying in lot of problematic situations. Inadequate manpower, we all know. The same thing is there in the education. There is a lot of corruption. The nursing colleges are having a lot of corruption, and we can see there is a bureaucratic model which is there, and that hits the nurses a lot. And the similar thing was found in the medical colleges also. So it is not only the nursing part, I think it is a systemic issue which we have to work on. Then if you go the other factors, there are a lot of other factors related to the whole healthcare system is the political, social determinants and the economical part. Our healthcare budget itself is 1.9, which is less than 2%. And that itself shows that nobody is interested in the public health sector and everybody is pushing the buck to the private health sector. And that is going to be a big problem in the coming future because the quality of the doctors and nurses is going to be very bad, and the whole problem is going to be faced by the patients who is going to pay but is not going to get the care. So you can see the whole problem which is going to happen is that there are not going to be right people at the right places, and this is going to be a big issue for not only nurses, but all the people who are not in that zone of power game, I think. And UHC is going to be a big problem for all of us. We cannot achieve that. Okay. I'll not take this slide now. So we did some study during COVID. We did a rapid assessment in the Maharashtra about how the nurses, what problems the nurses are facing. And what we found was that nurses were again in the most lowest rung, and there were a lot of issues in the private sector. Public sector, at least they were getting PPE kits, but in the private sector, they were not getting PPE kits. The conditions were horrible. The issues faced by the nurses were so much that they had not been allowed to go to the hostels. The hostels provided by the private sector was not taking care of the nurses. Private care nurses were not getting paid. Private care nurses were threatened. There was no budget given for care. All these issues were big problem for the nurses. And somewhere we also saw that even the doctors who are working in the private sector had these issues to face. So what we got the recommendation was that the state should intervene and they should regularize the private sector. The vacancies which are there, they should be filled both in private and public. Provision of high quality safety measures should be provided both in private and public hospitals. The governing working conditions of nurses, especially in the private sector, the contractual nurses were literally removed on the day of the duties when they saw that they are no more needed, and they were out of job completely. Also in government sector, where the contractual nurses were taken, they were also not given any contract documents. They were just asked to leave. So this was not a good sign. Increasing budgetary provisions are required in healthcare workforces. There is no grievance redressal cell for any healthcare workers, and that is the healthcare workers' right, and that should be in place. Regular wages and compensations for extra hours, which was very much needed during COVID, and I think even today that compensation is not given. Nurses and doctors are always working extra hours. So what we understood in various reports which were written by the nursing forums, we understood that healthcare is actually delivered by women and it is led by men. And this is what we found also in nursing, that even the 20% of men who are there in nursing, most of the men were found to be taking care of the unions. We don't have any women leaders in nursing unions. We also saw that these men were more interested in managing the hospital administration than giving the care to the patient. So this was one of the quite revealing factor which was not appreciated by women nurses, and this gender leadership gap, which is quite predominantly seen, that should be taken care of. That's what I feel. Women disadvantage intersect with, again, is with the multiplied by the other identities such as race, age, hegemonies, hierarchies, and class. Global health is weakened by excluding female talent, ideas, and knowledge. We saw this in both female workers as nurses, as ashas, as female doctors, and also technicians. Women leaders often expand the health agenda, strengthening health for all. This was proved, and gender leadership gaps in health are a barrier to reach the SDG and UHC. Missing of women healthcare professionals was very much seen in the COVID task forces. We didn't see any nurse in any task forces. We hardly saw women doctors in task forces. The gender distribution scale, if you can see here, male nurses are just 20%, 80% are females. But in other sectors, you can see that males are more and females are less. Even the representation at the global level, we can see that hardly there are very few women leaders who are running the show. Majorly, the healthcare sector is run by the males. This was a very predominant scene during COVID, strikes by doctors, nurses, contractual laborers. So this is one good slide which shows gender dimensions of health workforce, where the violence against women, that is the female healthcare workers, is very predominantly seen. And it is the division they have given at gender inequalities, gender biases, gender power relations. So again, in gender power relations, it is again dependent who decides what is valued, who does what, who has what is known. And in the gender biases, we can see that who is giving these gender discourses, who is making the gender decisions. And always we understand the person who has the power will be taking care of all these things. So gender inequalities, we have seen that hardly we have seen space for women. Hardly women professionals, nurses, ashas are recognized. There is a lot of unpaid labor by ashas and nurses, and also women professionals. We have seen that in medicine and technical firms in healthcare sector. So tackling gender power. Yes. I can't hear you. Tackling gender power relations is key to ensure the safety and well-being of healthcare workers and the ability to deliver quality care. This was the expert, Dr. Asha George, and her colleagues had to say. Way forward, I want to just give you 3 examples of how the advocacy movement can be a solution, or awareness movement by the healthcare workers can be a solution for these gender biases. So in the nursing part, what we saw is that the UNA, IPNA, and other unions, okay, they came ahead and they literally fought for the minimum wages with the Kerala government, and they have won the case. But unfortunately, still the minimum wage is to be given is 20,000, but still it is not been implemented. So even if you fight out, you don't get what you win. That is one thing what we have understood. And one most important thing I feel is that when we come all together, instead of just being nurses or ashas or female health workers, if we all come together, I think our voices will be heard and we can really bring change with unity. The same thing we saw was in Maharashtra State Association of Resident Doctors, MAD. They had also the same issues, and they also had to fight it out for their salaries during COVID. Ashas, we all know, they are still struggling. And though they are honored by WHO, but still Ashas hardly get even 5,000 rupees per month. Their work is more than 8 to 9 hours per day, but nobody is taking heed of them. With this, I would like to end my session. Thank you so much.
Thank you so much, ma'am. That was highly informative and interesting. I would now like to invite the chair, Professor Vibhuti Patel ji, for her remarks to the session. Over to you, ma'am. Ma'am, you're on mute.
Hello. Yeah.
Yes, ma'am.
So, Dr. Swati Rane, you made a very comprehensive presentation on the socioeconomic and the administrative aspects of existential struggle of the nurses in India. But India is the country which exports highest number of nurses to several countries, not only industrialized world, but even in the developing world. That was what do you have to say about that? And second one is that does private practice in nursing individually, when you do private practice, is it more paying, or is there more dignity when nurses practice privately instead of joining any hospital? Now, current budget has also promised starting new nursing colleges alongside medical colleges. What do you have to say about that? Is it going to be beneficial to both nurses and also the patient care? Yeah.
Okay, first I'll go for the migration part.
Yeah.
We all know that India is known for exporting nurses all over the world, and Indian nurses are always in demand. Unfortunately, the way currently after COVID, the demand has come in is being so unstructured, and I think even the countries like Germany or England, they are not having proper contracts for these nurses. And that is a very fearful situation, because we have seen cases where the uh, the the people, the ones who are the agents, we can say, who are taking these nurses, they are not even registered. They are just the ones who are doing recruitment for other professions. They are the ones who have come in, and and Indian nurses are so lured by these agents that they just take up any jobs and they go, and they are still in problem. And after going there, the problem they realize, but they don't want to talk about it also, because they don't want to come back to India. So they have a double struggle there. So many nurses they have reported to us that what they were earning, they are earning lesser than what they were earning in India. So Indian government should really bring some regulations on these recruitments, international recruitment of nurses. Yeah. Second question is about, I missed it.
Second question, yeah, is about the union budget has now promised to start nursing colleges alongside the medical colleges.
Yes, that is a welcome move, because always nurses are needed in India. But unfortunately, we are not prepared to have so many colleges, because we don't have that many professionally experienced nursing teachers.
That's
yes. And for any profession, especially in health sector, you need teachers who know about the care part of the patient. You cannot have theory based, you need practical based also. And that is going to be a big challenge for these hospitals.
I have shared the report on leadership gap prepared by WHO, when it says that 70% of health workers are healthcare professionals and the workers are women, but you hardly see 5 to 10% in the leadership. So that report it's there in the chat box. Yeah.
I will share the reading list maybe after the presentation.
Yes. Yeah, you can share it in the chat.
Thank you very much.
Thank you so much. Now the floor is open to questions from the audience. You can write your questions in the Q&A box or raise your hands and unmute and speak. If there are any questions, please go ahead and ask your question.
Kamlesh Guliaji has written, and yeah. And she has, Aishwarya ji has written that she would like to read articles showing by evidence examples how women leaders expand healthcare for all. That is there in the WHO. Okay, yeah.
I just wanted to just raise a point that I have worked both in government hospitals and in private hospitals. So the one thing I observed from doctor's side, that in government hospitals, doctor don't want to go to perform the duties. So they will give more freedom to nurses, that you operate by your own and you are talented, and they will praise the nurses to keep them happy, and you do the deliveries, normal deliveries like obstetrician will ask nurses to do. But in private sector, obstetrician is getting lots of money and the patient wants a doctor to perform the normal delivery. So in private sector, there is restrictions on the nurses that you should not cross the boundary and do this work. So I feel this is very injustice towards nurses, and it's cruelty also, like how we use them according to our needs. So yeah, that just I wanted to
But
add
this
that.
was there even in the 70s. All the camps which were conducted in the PHC, you hardly saw doctors because it was only the nurses and other support staff. They were running it. Doctors, they never came because in the public health facilities and primary health centers, basically the poor people go and poor women go. So
Yeah,
that's true
right.
there also. Yeah.
Because I work in a tribal area of Chhattisgarh, and my nurses were very skillful and they were resourceful, and I used to enjoy working with them. They were also happy. But when I came to Maharashtra in private sector, nurses look very timid and scared and anxious. So I really feel so bad seeing that.
No, I think related to that, I would like to know from Dr. Swati Sawantrani, how are nurses treated in those 5-star, 7-star corporate hospitals? Is their condition better as compared to small nursing homes and all?
Actually,
Accountability system, standard operative procedures, safety at workplace, internal committee to address sexual harassment at workplace. All these things are there in the corporate hospital.
Internal committee, unfortunately, are just for the namesake in private hospitals. In corporate hospitals, also, I have observed the same thing, because in corporate hospitals also, if you see major sexual assaults and abusive cases come, and which are hidden, they are not allowed to come up. And that is one of the big problem in private healthcare, because the nurses don't feel safe there. And even the committee is as per the private hospitals management. So you don't have really the actual committees which are going to safeguard the victim. It is going to safeguard the hospital. So that is one important part which I should have said it in my presentation. I missed it. So that is one part. Second part, the private hospitals in India hardly have nurses. They have nursing aides called as nurses. So they are not registered nurses, and that is one of the reasons they are so timid. And in the private corporate hospitals, there are licensed nurses, but they are not having that much of experience. So that is one of the reasons they are so timid. On the other side, if you see in the government hospitals, they are licensed, they are experienced, they know their work, and that is the reason they can perform better than the doctors. And that is the reason doctors have more faith in them, and they allow them to do the normal deliveries, and sometimes even complicated normal deliveries are done by the nurses. Yes.
Yeah.
Any more questions? And thank you, Doctor, for giving us that share, that you found that government nurses were more better than the nurses you saw in private sector. Yes.
Not
And
better. Timid. They were stronger. Here they were timid.
Yeah, and in the private sector, hardly you see a nurse with not more than 2 years of experience. In government sector, there are more than 14 years, 15 years of experience nurses.
Yeah.
I think there's a raised hand by Christianity. So if you want to go ahead, please.
Yeah, please go ahead.
Hello everyone. And this is just something that I had noticed. Actually, I am a child of doctors, so I was around people who ran these private clinics. I know that there are many nursing aides, they are not actually registered nurses, but they would also be used by these doctors to make them do their housework. Like, if
We
these
have
clinics.
we have nurses telling us that when they were not they were not licensed, they were waiting for their license to get, and when they were working with the private doctors, when there was no patients in the rural hospitals, the private doctors used to ask them to get water from the well for their household. So it is a power dynamics what is there, definitely.
Yeah. And I think even in the most super specialized hospitals, nurses have to surrender their passport too, and give the undertaking and bond, because in Bombay there was a big strike also by the nurses, because
now bond system has gone. They are not allowed, the hospitals are not allowed to sign a bond or keep their certificates or passports. That is not there, but there are still some places where they do these things.
no, in the most posh area of Mumbai, BKC, I had
Yes.
seen nurses fighting for that, the
Yes,
with the cards.
yes,
That
yes.
please give back our passports.
Yes, that was because of that BKC hospital only. The unions had fought for that nurse who had committed suicide, and
Yeah.
after that bond system was erased from the system, healthcare system, which was not legal. It was not legal to keep anybody's certificates actually.
The modern form of slavery. Yeah.
It's a form of slavery, but you can see the same things which are happening with the other doctors also, medical professionals also. Though they may not keep their certificates, but they are scared to go away from the doctor because they may not give them good reference note. So this is again a hegemony or hierarchical system seen in the healthcare sector. So what I feel is that if we all people who are vulnerable or marginalized in healthcare sector, if we come together and we ask for a system for the organized and unorganized sector from the government, and with a political agenda with it, which I think Jan Swasthya Abhiyan is doing. With that, if we join, I think we can bring some change definitely.
Even Jan Swasthya Abhiyan played a pivotal role in seeing to it that the relief kits and menstrual pad were given to transgender persons during the lockdown. Even the for sex workers also, that they also deserve relief kit. Before that, it was only stigma and brutalization was happening after the pandemic. It was Jan Swasthya Abhiyan which played a pivotal role by approaching National Commission for Human Rights and also filing public interest litigation.
And also the regulation policies have to be formed, the regulatory acts which are not yet brought in various states, they have to be acted out. And that is the most important thing which I think is missing. And even in our education system, in healthcare, policy, acts, legal part, gender part is completely missing. We are just concentrating on the patient and the clinical aspects. And that is one of the major drawback I feel, that we are not oriented to understand that we are being we are created as a slave, not as a practitioner, unfortunately. And we can also see that even the doctors and nurses, if you ask them to start a union, they feel union is a bad word. So you hardly find any doctors union or nurses union coming ahead to fight for themselves. So advocacy part is very much needed. The way Asha said, taking up advocacy for themselves, I think nurses and doctors also should come up and do the advocacy movement for their own profession.
Yeah. Very important. I think today's all three presentations are hardcore, though heartbreaking and hardcore reality, but I think the change is possible. They also generate optimism that if we don't just remain onlooker, but we also get involved and take stand and take side whose side we are on, whether it's a gender-based violence or the rights of queer and transgender communities and also nurses who are at the subordinate position in the hierarchized medical profession.
So the first problem the nurse identifies. And if she is not having advocacy for herself, how can she become patient's advocate? That is the most important question I feel every person should ask. And I think now, instead of asking their rights from the government, I think they should go to the patient who is the actual client of theirs, and they should form a team up with the patients, and
Yeah.
the patients union, they should help.
No, but Dr. Swati, you have become like this assertive, because in the syllabus of nursing college, I remember in the 80s, I was in the syllabus committee of SNDT's Lady Thakursi Nursing College. We introduced a special module on assertiveness training, how to be polite, but at the same time assert our rights, because rampant cases of sexual harassment were found. And even people, though, especially in the luxury ward of the Jaslok Hospital and all, which was taken away by the Arab sheikhs, and the way they would pull their skirt and pull their sari and all sorts of things. We even had a morcha in front of that hospital. No?
And still it is happening. It is not that it is not
Yeah, but
happening.
now that time, like so many changes took place. So I think all these issues, which are of a ground reality, very painful, heartbreaking reality, that has to go in the syllabus so that you are prepared. You are not caught unaware, no? Because
No,
you
but
talk about
education-
Florence Nightingale. I have even attended your convocation ceremony of the nursing college. Beautiful, with all lamp lighting and
But many of our senior educationists are not ready to talk about gender and the sexual assault, because they think that if you talk about them, the nurses will leave education and go.
No, but after Aruna Shanbag, things have changed, no? You can see how the KEM hospital has come up. They started a course on gender, online course also.
Yes, but I think the movement has begun. There is a lot to be done.
Yeah,
And
that is there, but there are good initiatives taking place, and we all have to combine our forces and see to it that
and it should be a part of syllabus, as you rightly said, that you have added the course, but if it becomes a mandatory part of the syllabus,
it should be core component. It should be core component. It should be in the foundation course. The way, or even engineering colleges, School of Architect, judges training, everywhere now gender has become a part of core, either a foundation course or orientation program, or pressure course or faculty development program, or the core component within the syllabus, which each and every professional or a student has to clear.
Okay. And the faculties are not that, having that much of freedom to talk about.
No, that's why it has to happen at a level where the syllabus committees, textbook writers, at that level we have to reach. Yeah.
Yes. Thank you.
Thank you.
Thank you so much.
Very good session. All three sessions were really good. Power dynamics and doctor solidarity neglects and suppresses, correct? It's an old boys club, no? It is always, when it's not only in your medical profession, it is there in academia, it is there in politics, it is there in administration.
Especially because of this unregulated things happening in the private sector. The courses are run by the private medical colleges. This is very rampant, and many female doctors we have come across who have really complained, but their complaint goes unheard.
No, so I think now the target should be Indian Medical Association and Medical Council of India. While someone has to get into it, see to it that you win the election, because agenda setting power is important, not just representation. Because the WHO report clearly says 2/3 of the health workforce is women. But why don't buy even 5%? You have one Soumya Swaminathan and Dr. Jesani told us. Who else is there? So I think we need to target, systematically see to it that those who are vocal, who are articulate, who are committed to the profession, and who care for other people, like who believe in solidarity, they get into such bodies, no? Yeah. And that too in good number, because 1 or 2 can be silenced and witch hunted. But if we are in a good 5, 7, 10 of them, then you can put forward
the structure itself, our INC president itself is a male, and who is there?
I know, doctor.
70 years.
Yeah.
That is a big joke about nursing profession.
Correct,
we are having such a man of who has crossed his retirement age, and still he is the president of INC, and it is a shame for us as a nurse.
Indian medical. Correct. Yeah. Great session. Yeah. Enlightening discussion. Very good. Yes.
Thank
Yes. Yeah.
So we
And
can,
both the documents are there, huh? PDF. I have multiple times shared them on chat box at 8:08 p.m. and also 8:09 p.m. You can see WHO Leadership Gap Report and also family violence in the lives of queer and transgender. So you can easily download them. Yeah.
Thank you so much, ma'am. Moving on, I would like to invite Professor Vibhuti Patel ji for her closing remarks. Kindly.
Hello. Now we are concluding. Hello.
Yes,
Ah,
ma'am.
okay. So thank you very much, all the participants, for being every day. We have been exceeding time limit, but the discussion is so rich and so many inputs are coming. And today, I think we started with a very participatory way of discussion on domestic violence, and also all the 3 case studies which Padma Deosthali ji shared with us. The response was also very good. And Dr. Aqsa's presentation is a very important, because now some big thinking has started, the discourses have started, and the question also comes in the rubric of all the uh, violence is one aspect, but not getting entitlement, citizenship right, and the opportunities, that is also very important issue. What she said about the latest law, the Transgender Persons Protection of Rights Act 2019, that also doesn't talk about what kind of uh, developmental investment state is ready to make, which already Tamil Nadu and Kerala has started doing it. They have given the example that if there is a political will, you can do it. They have finished the census of queer population. They have done the need assessment. They have provided in their state budget the housing facility, scholarships, job reservation, all that. So if the 2 states can do it, why can't the union budget do that? So I think that also is a very important question that we are asking, that whatever promises you are making, that promises have to translate into funds, functions, and functionaries. So that is a very important issue that she brought out. And also the double standards when we have by dealing with gender-based violence, that if any child or a woman get raped, then you have a 7 to 10 years of rigorous imprisonment. Why in case of trans person, it's only 2 years of imprisonment? Is their pain less important to the criminal justice system? Why these double standards? And second one is that who decides your identity, whether your use as a self you decide, or some doctor or a district magistrate will decide to and assign you identity. These are very important issues which Dr. Aqsa also discussed, and Dr. Swati's thing, which is the most neglected section in the healthcare hierarchy, is a status of nurses. They are facing, as Dr. Jesani told us, the triple burden. It's not only the burden of being subordinate in the medical hierarchy, but also being the gender. And most of the nursing, they also come, the class bias is also very much there. The class background of the doctors and the class background of the nurses, in that also there is a gap. So this triple whammy also creates multiple marginalities, and that is why solidarity, collective endeavor, and also changing the mindset of people. So in all 3 issues, whether it is gender-based violence or the predicament of the queer and gender diverse population, and in case of nurses, there is a common thread, and that thread is of solidarity. Thank you.
thank you.
Thank you so much, ma'am, for your valuable remarks, which very well summarize the entire day. Now I would like to propose the formal vote of thanks. As we come to the end of the 3rd day of Healthcare and Gender Equity, Cohort 3.0, theme Advancing Systems, Structures and Policies to Address Contemporary Challenges, an online international monsoon school program, a 4-day immersive online certificate training course organized by IMPRI. I, Samprikta Banerjee, researcher at IMPRI, Impact and Policy Research Institute, would like to propose a formal vote of thanks on behalf of the IMPRI Gender Impact Studies Center, GISC. We are grateful to our experts for the day 3 sessions. Dr. Padma Deosthali ji, Dr. Aqsa ji, and Dr. Swati Rane ji for taking out their valuable time and for their thought-provoking insights on the topics. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for this session have been shared in your email, and a video of the session will also be shared with you for learning. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publications. The feedback forms will be shared at the end of the course. Kindly fill it in to get your certificates on your email ID. We hope you continue to join in the future to our IMPRI Web Policy Talk and Web Policy Learning. With this, we come to the end of the third day of this course. Wishing you a good evening. Thank you so much.
Thank you, Samprita, for your moderation. And only, am I getting your voice is quite faint. Is it for all or it's only me?
Very less voice.
Acha, it's for all, no? Acha, so there is nothing wrong with my computer. Okay, fine. No problem. No problem.